Monica, you can go ahead and kick things off.
Kim,
Yep, go ahead, Monica.
can I start?
Yes.
Okay. Good morning. My name is Monica Wallace. I'm a registered nurse in long-term care setting. My background is critical care and long-term care for over 20 years. And I'm going to be presenting on multi-drug resistant organisms in the long-term care setting. For multi-drug resistant organisms, there's novel MDROs, and that's an organism with a resistant phenotype or a resistant mechanism that has never or very rarely been identified in the United States. Often experience with these organisms is very limited. So these are ones that not like your traditional that you would know, the MRSA, the VRE. These are things that we don't see often or we have never seen in the United States. Targeted MDROs are organisms resistant to most or all available antimicrobials, and they have the potential to spread widely. There's intensive public health actions that are required to slow the spread of the targeted MDROs. And the targeted MDROs can vary from region to region. So you would need to check with your local Department of Health to see what they are targeting for your area. Examples of the MDROs currently being targeted by the CDC, they're pan-resistant organisms, CRE, Candida auris, and some other ones, as you see here, that I'm not even going to try to pronounce. The ones that are most common that most of us know about are the MRSA, ESBL, VRE, Pseudomonas aeruginosa, and strep, resistant strep. What causes multi-drug resistant organisms? It's usually the overuse of antibiotics or taking antibiotics when they're not needed. Many times people will call their physician and say they have a sore throat or they have a cough and they request an antibiotic. That's not good because the overuse is what does lead to the multi-drug resistance. At first, only a few bacteria may survive the treatment with an antibiotic. But the more often those antibiotics are used, the more likely that you're going to develop a resistance to that bacteria. So it's best to not take antibiotics unless there's a true infection, and only a physician would be able to determine that. And generally that would be confirmed with lab work. How do they spread? They spread from patient to patient. Most of the time they spread on the hands of healthcare workers. They can also spread on inanimate objects such as medication carts, handles, bed rails, bedside tables, IV poles, catheters. They can also spread from person to person through direct contact. So we need to make sure that we are using proper hand washing and proper environmental cleaning so that we are not causing that spread. But generally, hand washing is the biggest way to prevent this. Some of the risk factors, in general, people who are healthy, they're at the low risk of becoming infected. Your risk goes up from there if you have an existing severe illness, underlying diseases, diabetes, chronic kidney disease, open wounds. If you have previous prolonged use of antibiotics, that also puts you at high risk. If you have any type of invasive procedures or use of invasive medical equipment, dialysis, Foley catheters, IVs, anything that is in your body, other than implanted devices like pacemakers. Frequent admissions to the hospital or regular dialysis visits because you are in a medical setting where you could have potential exposure. a long hospital stay, because again, the biggest way that it's transferred is from the hands of healthcare workers. If you have a previous colonization with a multi-drug resistant organism, you are at higher risk for developing an infection, a multi-drug resistant infection. History of healthcare abroad, it's very common. If you have care abroad, especially in the third world countries, where infection control might not be as prevalent. If you're elderly or on any type of immune suppressing medicine, any type of chemo medication, to prevent MDRO colonization or infection is challenging in nursing homes. And there's some factors that handicap us in the long-term care setting. We have limited trained infection preventionists and environmental services in nursing homes. Many times, we just don't have the staff to properly do it. So it has to be a priority. There's low funding, frequent staff turnover. So if you do educate, you have to continue educating. This is an everyday thing, and it needs to be touched on every orientation. And then it needs to be reinforced daily. COVID-19 infections, high-risk patients, like we spoke about before, the comorbidities, advanced age, and indwelling devices. Long-term stay and communal living situations, shared rooms, communal areas such as dining rooms, activity rooms, therapy rooms, and infrequent terminal disinfection. All of these handicap us in the long-term care setting to prevent these MDROs. A colonization is different than an infection. A person who is colonized with a multi-drug resistant organism is carrying the organism in their body, could be for years, but the organism isn't causing them any symptoms or making them ill. So they may not even know that they're colonized. People who are colonized with an MDRO can, however, spread that organism to surfaces in their environment and to other people. And many times, like I said, people do not know that they are colonized. To have an actual MDRO infection, the person who is infected with the MDRO has the organism in or on their body, and it is causing symptoms or illness. A person who's colonized with a targeted MDRO or any MDRO can also become infected later with the organism. So like I said, the targeted ones are the ones that the CDC is targeting because they're the newer ones and they're very hard to treat. But any MDRO can cause you to go from colonization to infection. You need to have a plan to promptly obtain additional resources, like transmission-based precautions, enhanced barrier precaution, door signs, and I will touch on the enhanced barrier precautions shortly. Education is the biggest thing that you can do for your staff to try to prevent the transmission. Cleaning supplies, to have an adequate amount of PPE. When a resident is identified as infected or colonized with an MDRO, you need to make sure you review your facility policies regarding enhanced barrier precautions, because they're a key part of the facility's response to the presence of a targeted MDRO. And enhanced barrier precautions are a newer thing that the CDC has put out to try to manage the risk of the targeted MDROs. So you should be reviewing your facility cleaning guidelines, identify potential gaps, observe routine housekeeping procedures to identify cross-contamination issues. I've seen, people use the same cloth from a clean bathroom surface and then wiping down ice buckets. So you're transferring germs. They might use the same mop from an isolation room and then go to a clean room. So you always have to reinforce the process. Identify high-risk surfaces. There's many high-risk surfaces in the long-term care arena. High-touch surfaces in shared areas such as tub or shower rooms. and shared medical equipment. Develop an outbreak-specific cleaning plan to supplement routine protocols. Somebody is asking me, where can we find a list of these MDROs? If the question is the targeted MDROs, you can get that from your local Department of Health. Because like I said, it does vary different. It varies from region to region. But you can reach out to your local Department of Health, or the CDC could guide you as well. Good question. We need to provide regular information to residents and staff. We need to make sure there's in-services, notices, posters. We need to reinforce the facility policy regarding proper hand hygiene. Like I said, that's the way that it is most easily spread from the hands of healthcare workers. So hand hygiene is super, super important, as it is in many other things, and no different with the MDRO transmission. Ensure that there's adequate access to hand hygiene stations and supplies. Many times, you'll be in a situation and you'll leave a room and there is no hand sanitizer in the equipment. So make sure that there's this routine schedule to have those filled and checked. Need to make sure that paperwork and verbal reports received for new admissions and readmissions to your facility include a review of residents' MDRO history. Anybody with an MDRO history is at higher risk to develop an MDRO infection. Ensure that paperwork and verbal reports, that's the same thing twice, sorry. So for hand washing, like I said, it's the most important thing to prevent this. It's the easiest way to transfer it from patient to patient, from the hands of healthcare workers. So make sure that hands are washed with soap and water for at least 20 seconds, always before handling any food, always after using the toilet. If your hands are visibly soiled, if they've had contact with any blood or body fluids, hopefully there will be gloves involved as well. Before and after assisting residents with toileting or perineal care. Even obviously you would be wearing gloves, but hand hygiene needs to happen regardless. Beware of rings because they can trap the germs and it can get caught on clothing or equipment. You can scratch patients with it. You can cause wounds. Dry your hands thoroughly with a paper towel. Turn the water faucet off with the paper towel and make sure not to touch the dirty sink handles with clean handles. A lot of places now are going to the little foot pedestals on the bottom of the doors. So when you do leave a bathroom, you don't have to touch the handle. So those are really great ideas to think about implementing. If healthcare workers must wear a ring, they should leave the ring on their finger and wash and clean the ring along with the hands, not take it off and then put it back on. Because you want to make sure the ring is clean as well. And you're not putting it on dirty hands. Hand sanitizer may be used in all other hand hygiene situations not mentioned above. Make sure your medication and treatment carts are stocked with alcohol-based hand rub or alcohol hand wipes. And make sure that there is a process for checking those. And make sure you always have enough on hand. You have PAR levels that will meet the needs of the facility. Suggest setting up a routine system to monitor how and where staff are cleaning their hands. Doing spot checks, stopping somebody and watching them, because when survey comes in that you want to do this right all the time, but many times that's something that the surveyors will get you on because somebody didn't wash their hands appropriately or did so for the right amount of time, but maybe didn't turn off the faucet correctly. So hand hygiene is extremely, extremely important. High-touch surfaces, they have to be routinely cleaned and disinfected, especially in between use on the residents. You don't want to spread germs like that. When cleaning, consider the contact time for the product. The contact time or the dwell time is the length of time a disinfectant needs to remain wet on a surface to be effective. So the bottle of the cleaner will tell you the contact or dwell time. And if you were to spray and wipe it right off, you are not actually killing the germs. It has to have the appropriate amount of time that the cleaner tells you so. Clean and disinfect high-touch areas. Now, there's many high-touch areas. I just touched on a few here. Doorknobs are a big one. Counters, medical carts. Make sure that you have a routine cleaning schedule for the medical carts. Tables, the overbed tables are something where, there's a lot of germs on those. Those should be cleaned before and after meals. You don't want the patient eating on a tray full of germs. Bed rails, that's a biggie, especially if we have incontinent patients that might, get germs on their hands, they're touching their bed rails. So those do need to be taken into account and cleaned on a proper routine. Phones, especially cell phones, call lights, personal care white packages. That's one that we generally don't think about. But that material is porous and it does hold germs. You want to make sure there's proper notification and communication so that people are aware that that a person does have an MDRO and is able to protect themselves and the residents properly. So your internal communication and signage needs to be there. When a targeted MDRO is identified in a facility, the communication between the people caring directly for the patients and the housekeeping staff is extremely important, because everybody needs to know this person has this drug-resistant organism, not just the people caring for them. Housekeeping staff is equally as important, and really anybody who will be having contact with this patient. Staff who will be entering the rooms of residents who are on transmission-based precautions should be made aware of appropriate control measures prior to entering. And you can do this by putting the instructional signage on the door. And you can also do that on the resident's medical record. Generally, the door signage works very well. Many people don't go to the medical record to look before they're going in, especially housekeeping and other departments. So the instructional signage on the door is very important. They're intended to signal to individuals entering the room on exactly what they need to do to protect themselves and the resident. So the sign should contain the information and the type of precautions, contact precautions, enteral precautions, droplet precautions, whatever the precautions may be, and the recommended PPE to be worn when you care for these residents. Generic signs that instruct individuals to speak to the nurse, those are not adequate to ensure precautions are followed. I think that's more old school. I haven't seen those recently in my practice, but some places may use that. And many times, unfortunately, people do not go see the nurse, or the nurse is busy in another patient's room and they can't get the information they need. So they go in, and at that point they expose themselves and potentially the resident. So the sign should be instructive as to what to wear for PPE. And these signs, I do have some examples later on in the presentation, but they are all available from the CDC website, or your company may have specific signs. Signs should not include information about their diagnosis or the reason for the precautions, or even the presence of the resistant pathogen. That would violate HIPAA and a person's dignity. So you do not say somebody has C. diff, somebody has VRE, somebody has MRSA. You only indicate what needs to be worn in order to care for that patient. The external communication and transfers to other facilities is extremely important as well. And that's goes both ways. That should be from the hospital to you. So you want to make sure you're asking questions if you're receiving a resident, and you want to make sure that you are providing information if you are transferring a resident. The importance of clear and timely communication between facilities when someone is colonized or infected can't be emphasized enough. The people transferring them should know what that the person has specific needs for precautions, because the cycle can happen. You can spread this anywhere. So our goal is to not spread it. So anybody in contact with this patient should be made aware of the proper PPE that needs to be worn. When a resident has a targeted MDRO and is transferred from one facility to another, the receiving facility must be informed of their MDRO history and status. And ideally, prior to transfer, they should not get that information once the patient has arrived in their building so that they can be ready for that patient. And by being ready, they may need to make specific room changes. They may need to put them in a designated hallway or have designated staff. So all of this is something that should happen prior to you sending a patient out. It should not happen once a patient is received by the new facility. And vice versa, this is the information that you should be receiving from the hospital if you're taking a patient from the hospital or any other type of transfer. But these are questions many times that you need to ask or have your liaisons ask so that you are prepared, because it can turn into a disaster when someone arrives in your building and you had no idea that they have VRE and you have them scheduled to go in room 111 and A bed and B bed does not have VRE. So it's just a lot of scrabbling. You know, when that happens, it's a lot more work on the staff and you're putting patients at risk. So make sure your nurses are educated to ask, because sometimes, unfortunately, they just don't offer that information. The following information should be communicated to the receiving facility. The basic information about the resident and transferring facility, why they were with you. It could be that if you're in a long-term care, they were there as a short-term care patient and they're transferring to an assisted living or whatever their next level of care is. Or if they're going back to the hospital. And that's irrelevant of whether you took that patient from that hospital and they had the MDRO coming into you. You need to make sure that you are still communicating that information back to the hospital and to the transport, because many times they're going to take the patient to the closest hospital, which might not be the hospital they came from. Or if a hospital is on divert, they're going to send them there and they would not have that information. Make sure you're providing the resident's name and date of birth, the facility transferring name, the name of the person reporting and their contact information in case they have any questions, their history and current status of the multi-drug resistant organism, the organism name, VRE, CRE, whatever it is, the specimen type and collection date, something that is, it doesn't always happen, but it would be great if you were able to send the lab report with them, and the collection date. And does the individual have an infection or are they colonized? And like I said before, you can be colonized, have no symptoms, and not even know. But if you do know, then you should be letting the facility, the receiving facility know. Are they currently being treated for the infection? And if so, where are they in their treatment? Is it something that they just started? Are they on day 12 of 14? If there were 14, let's say it was a 14-day treatment, did they miss any doses and maybe need an extension to complete the full 14 days? All of that information is very, very important that you should tell the receiving facility. Ideally, this is a phone call so that the person on the other end understands it and is able to ask any questions that they may have. Otherwise, they only have what you provide. So ideally, a phone call is best. Many times, I know it's difficult to get someone on the phone, especially in an ER, but it is very important that we minimally try and document that we tried. At minimum, the MDRO status information should be included in the transfer paperwork. That's at very minimum. So surveillance and outbreak identification. So there's examples of surveillance activities, maintaining line lists of residents known to be infected and colonized with targeted MDROs. You don't always know, but the ones you know, you want to have on that line listing. This is going to be per your facility policy or by your local DOH guideline. Whether you obtain cultures of all high-risk residents on admission to detect colonization or infection. In my practice, I haven't seen that often that they do for any admission. But again, your facility policy may be different. Perform testing to determine the extent or spread of the targeted MDRO within the facility. So this is when you have an outbreak. So you will reach out to your local Department of Health and they will guide you. Sometimes you do broad-based testing and you're going to test the whole building. Sometimes it also depends on exposure. But really the local Department of Health will guide you on that. And sometimes it's just a specific unit or a specific hallway. But again, the local Department of Health will be your best friend on that. Management of these residents, you want to promptly obtain extra PPE because your gown and glove usage will increase during an MDRO response. You want to estimate the quantities of PPE that you're going to need, taking into account staff room entry practices. So you definitely want to have PAR levels and emergency backup PPE. And you want to make sure that that's being checked on a regular basis. It's also going to take into account policies for grouping cares, current burn rates, and other facility-specific issues. Ensure signage noting the type of precaution is posted on each resident's door, like we spoke about earlier, with what type of PPE. And whatever type of PPE is required on that sign, you need to make sure it is available outside of each resident room that requires it. Some places use the over the door units. Some places use the carts outside the door. But there needs to be something, and that also needs to be on a cycle of being checked on a schedule to make sure that it is properly. You have enough of what you need. So somebody needs to be designated to check that. That's very important. Because if there's a call bell ringing and somebody's falling, you have to have that stuff right there. You don't have time to go digging for the equipment. So that should not ever run out. Early identification of residents who are colonized or infected with an MDRO, paired with immediate implementation of the proper precautions and the increased environmental cleaning. All of that is critical to mitigating the risk of the transmission in your home. You need to have the following plans and resources in place that will help to ensure, or that you're following the plans and resources in place. That'll help to ensure your facility is prepared to respond. Provide alcohol-based hand sanitizer throughout the building. You want to promote frequent hand hygiene among staff, residents, and visitors. You may want to make sure it's available for each resident room. Ideally, it would be both inside and outside the room to provide access as part of the PPE donning and doffing process. You might want to put hand hygiene signs throughout your building so that visitors are also aware of hand hygiene because it's spread on the hands of healthcare workers mostly, but anybody's hands can spread them. So the people that are coming in to visit your building should be equally as focused on washing their hands. And again, they don't want to take this home to their families. Keep garbage cans near the door inside each affected room to facilitate proper doffing and immediate disposal of the used PPE before you leave the room. You don't want to come out of that room with your PPE on. You'll be spreading it. Standardizing the location of the garbage cans will help reinforce a consistent process for the staff. Not only when you exit the room, but also when you're providing care for multiple residents in the same room. You may have a room that you're cohorting to patients with C. diff. I'm sorry. Staff should also know how to remove the PPE and how to don clean PPE for the next roommate when providing care in double occupancy rooms. And really, they need to know how to don and doff their PPE, irrelevant if you're doing it in a double occupancy room. That's something that they should be competencied on, minimally yearly. If there's an outbreak, I would make sure that I had education and competencies put in immediately. That's something that the Department of Health does look at. They will ask for your competencies in many instances, so you want to be prepared. And it also prepares your staff to better take care of the patients, as well as not taking anything home to their families. So you want neither extended use or reuse of gowns and gloves is recommended for mitigating shortages in the context of precautions for the targeted MDROs. Again, the targeted MDROs are going to be different from region to region, but it's like the CREs, CRS, things like that. So you never want to reuse these gowns. So you need to make sure that you go through your burn rate, that you have a proper amount of PPE on hand. So CDC guidance recommends enhanced barrier precautions as a strategy to interrupt the spread of novel or targeted MDROs. So again, the novel MDROs are the ones that we don't see ever or very, very rarely. It's something in the United States. And the targeted ones are the ones that the CDC determines are the targeted ones for your area, like the CREs, things like that, the CRS again. Enhanced barrier precautions, they're different than contact precautions. It's an infection control intervention, and it's designed to reduce the transmission specifically of multi-drug organisms in nursing homes. The CDC put this together specifically to prevent or mitigate the risk of MDROs in nursing homes, and it involves gowning and gloving during high contact resident care for any resident that's known to be colonized or actively infected with an MDRO, as well as those at increased risk of acquiring an MDRO. So if you have an indwelling medical device, a Foley, an IV, a wound, they encourage the use of enhanced barrier precautions. The difference between enhanced barrier precautions and contact precautions: contact precautions require the use of gown and gloves or whatever PPE is appropriate for those precautions on every single entry in the patient's room, regardless of what you're doing for them. It doesn't matter if you're going in there to provide very minimal care or extensive care. For contact precautions, you're to wear full PPE. That patient, they're given dedicated equipment, and they're hopefully placed in a private room. When private rooms are not available, sometimes they can share the room with a resident with the same pathogen. Ideally, it would be a private room, but if you have 2 patients with C. diff, many facilities do cohort. Residents on contact precautions are recommended to be restricted to their rooms, except for medically necessary care. That includes restriction from group activities, meaning pretty much everything. They generally do therapy in their rooms. They don't go to activities, communal activities. They don't go to a communal dining room. So contact precautions are not something that are supposed to be forever. They're generally intended to be time limited. And when they're implemented, there should also be a plan for discontinuation or de-escalation. So sometimes it could be when they finish their antibiotics. Many times, and again, this is physician driven, but some doctors want cultures to see if they're negative. Many don't. And then that would stop their contact precautions. But you should be working closely with your ID physician. They can help guide when contact precautions need to stop. Enhanced barrier precautions require the use of gown and gloves only for the high contact resident care activities, unless it's otherwise indicated as part of standard precautions. These residents are not restricted to their rooms, and they don't require placement in a private room. The enhanced barrier precautions allow residents to participate in group activities because they don't impose the same activity and room placement restrictions as contact precautions. And these enhanced barrier precautions are intended to be in place for the duration of the resident's stay in the facility. Or if they're enhanced barrier precautions because they have a wound or because they have an indwelling medical device, then you would follow the enhanced barrier precautions until the wound is healed or until the catheter is out or the IV is out, whatever is placing them at a high risk for a multi-drug resistant organism. When that is resolved, then the enhanced barrier precautions can be lifted. Otherwise, if they're colonized, you would want to use enhanced barrier precautions for the entire stay. So when should nursing home staff use contact precautions versus enhanced barrier precautions for a patient who does have an MDRO? So contact precautions are recommended if residents have acute diarrhea, if they have draining wounds, if there's other secretion sites or excretions that you are not able to contain by addressing, or for a limited period of time during a suspected or confirmed MDRO outbreak investigation in your building. If neither of those criteria are met and the patients do not have another indication for contact precautions like physician's orders, then enhanced barrier precautions could be used. Unless, again, you're guided differently by your local health department or your company policy. But for any of these infections, your local health department is going to be very informative in guiding you on what next steps should be, what precautions should be, and what time limitations. So once again, the difference between contact precautions and enhanced barrier precautions. With contact precautions, you gown and glove for all room entries and for all activities, regardless what you are doing for that patient. Private rooms are ideal for contact precautions. Again, if you have 2 residents with the same pathogen and you choose to cohort, you could do that. But ideally, you would want a private room. Room restriction, except for medically necessary care, if they absolutely have to go out for a dialysis or something. But otherwise, they are restricted to their rooms to minimize the spread of the infection. And they are recommended to be time limited. Nobody should be on contact precautions indefinitely. There's a social aspect to that. And there's many other things that come with that. Increased risk of depression, social isolation. So these should be time limited. Enhanced barrier precaution are gown and gloves only for the high contact resident care activities. They don't need a private room. There's no room restriction, and they can participate in communal activities. So these patients might have a wound, but it's covered and there's no reason that they can't come out. And they don't have particularly an active MDRO. And these are recommended for the duration of the stay. But again, enhanced barrier precautions are recommended for anybody with colonization of MDROs. Here is the CDC sign for the enhanced barrier precautions. It just shows what you should do. Everyone has to clean their hands before and after leaving the room. Providers and staff must wear gloves and gown for dressing, bathing, showering, transferring, changing linens, providing hygiene, changing briefs, assisting with toileting, any type of device care, any type of wound care, any type of skin opening that requires a dressing. And that's any type. That's a skin tear, a pressure wound, a diabetic ulcer, anything. And obviously you don't wear the same gown and glove for the care of more than one person. The contact precaution sign is different. This is everybody must clean their hands before and after entering the room. You put on gloves before room entry and you discard them before you exit the room. You don't want to be discarding your gloves outside of the room and moving those germs outside. Same thing for the gown. Everything should be discarded. There should be a trash can right by the exit of the patient's room. And that should all go into there. And again, people need to be trained and sometimes retrained on donning and doffing properly of PPE because they can transmit germs just by improper donning or doffing. And for these patients, there should be dedicated or disposable equipment, the yellow stethoscopes, the disposable cuffs for the blood pressures. And if there's any reusable equipment, it should be cleaned and disinfected before you use on any other person. And again, you have to monitor your dwell time. Residence rooms and cohorting per CDC. Single rooms, if available, should always be prioritized for residents who have acute infection with a communicable disease or residents with an MDRO placed on contact precautions for the presence of acute diarrhea, draining wounds, other sites of secretions or excretions that are not able to be contained. I have a question. How do we get our participant CE from this? That's something that maybe Kim can answer. I'm not sure the answer to that. I think she can probably answer at the end. So residents on enhanced barrier precautions can share rooms with other residents. However, facilities with capacity to offer single person rooms or create roommate pairs based on colonization can choose to do so. If you have multiple residents with a novel or targeted MDRO in the same facility, you definitely want to consider cohorting them together in a wing or a unit. You need to decrease the direct movement of the healthcare personnel from colonized or infected residents to those who are not known to be colonized, especially for a novel infection, because those are ones we don't know much about. So we don't know all of the precautions. We just don't know because it's something that hasn't been studied widely because it doesn't happen either ever or often in the US. When residents are placed in shared rooms, facilities must implement strategies to help minimize the transmission of pathogens between roommates. You want to maintain spatial separation of at minimum 3 feet between beds to reduce opportunities for sharing of items between residents. You want to make sure if your residents are awake, alert, and oriented, you can tell them, you should use privacy. Cleaning and disinfecting any shared reusable equipment, cleaning and disinfecting environmental surfaces on a more frequent schedule. You may want to develop a cleaning form that has increased frequency. But you need to speak with housekeeping for that because there should be increased cleaning, especially on high touch areas. Changing personal protective equipment if it's worn and performing hand hygiene when switching care from one roommate to another. It doesn't matter that they have the same pathogen. You still need to switch your protective equipment and wash your hands, obviously, in between patients. So age, comorbidities, invasive medical devices such as Foley's, PEG tubes, IVs, frequent antibiotic exposure, and dependence on healthcare workers in the long-term care setting. All of these increase the risk of nursing home residents becoming colonized or infected with multi-drug resistant organisms. All long-term cares are caring for more medically complex patients. We know that. They're coming to us from the hospital a lot sicker, a lot quicker after post-surgery. So they need to change and improve their infection prevention and control approach. The world is changing and long-term care has to change with it. We need to initiate barrier precautions on the presence of an indwelling device or a specific task, such as assisting with bathing. If somebody is known to be colonized or if they're at high risk. It's much easier for staff to understand and follow through with if there's a lot of education. So this approach can help decentralize the responsibility for infection prevention and control from a single individual to several staff members. So it's not only the CNA, it's not only the nurse that's responsible, but it's housekeeping, it's activities. Everybody's responsible. Even in therapy, they can be on enhanced precautions, and the therapist may need to gown and glove when they're doing specific tasks with these patients. If they're teaching them how to use the bathroom, they need to use the proper PPE for that if they're on enhanced barrier precautions. A shift to an approach based on risk factors can lead to improvements in infection prevention and control. I'm sorry, a shift to an approach based on risk factors. So we want to be proactive instead of reactive. And that also can support the quality of life, comfort, and dignity of the residents living in nursing homes. Any questions?
Thanks so much. I think everyone can hear me. I'm sorry, I'm having technical difficulties today. But I think we've answered all of the questions that have come through, Monica, within the chat and the Q&A features. So if there are no other additional questions, please, by all means, feel free to reach out to myself and Monica. We're happy to assist and get those questions answered. And Monica, thanks so much for bearing with me as I kind of toggled between a couple devices today.
No problem.
And I hope everyone has a great rest of their day.
Thank you.
Thanks.